Good evening, everyone. Thank you so much for attending this important conversation. Tonight, we are focused on discussing the unmet needs of Coloradans with severe mental illness, the implications of inaccessible care for them, and how to improve services for this population. A person with a serious mental illness is someone who has a behavioral or emotional health condition that results in serious functional impairment. Their condition also limits or interferes with one or more of their major life activities. Colorado ranked far below the national average for its number of adults with a mental illness who reported an unmet need for treatment in 2022. Coloradans are 9 times more likely to be forced out of network for mental health care when compared to primary care. People with behavioral health conditions tend to also have higher healthcare costs that are about 3.5 times higher when compared to other Americans who don't have a mental health condition. The need for good mental health care was made clear during and after the pandemic, and even so, we've seen problems with the mental health system persist. We've seen mental health organizations that care for people who need treatment close or almost close this year. Integrated Insight Therapy was shut down by the state earlier this year, for example, and we've seen and heard about the effects of its closure on people with mental illness in Colorado. West Springs Hospital almost closed its doors this spring because of financial issues and other problems, and its challenge to stay open is not necessarily unique. Other Colorado hospitals are struggling to keep up with increased expenses that outpace their income. And although we'll never be able to cover every issue within the mental health system tonight, my hope is that people here learn at least one new meaningful fact about mental illness during this conversation. I've handpicked 5 panelists to help us do that. Some have lived experience working with or caring for people with serious mental illness in Colorado, while the others have more experience with understanding and changing the mental health system here. These panelists were recommended repeatedly when I made calls to find experts for this event, and I would like to just briefly introduce each panelist before we get started. First, if you want to raise your hand, although your name is there, whichever works. So first we have Deborah Harrell and Sandra Sharp. Both are mothers who will share personal stories about how serious mental illness has affected their 2 adult children over the years. Vincent Atchity is the president and CEO of Mental Health Colorado, which works to improve the mental health system by changing laws and improving access to care, among many other things. Chief Judge Susan Blanco oversees a competency docket in the 8th Judicial District, and this program works to improve public safety and reduce recidivism by getting people who are deemed incompetent the services they need before they can begin to understand their court cases. And last but not least, we have Frank Cornelia, Deputy Executive Director of the Colorado Behavioral Health Care Council, which works to strengthen the behavioral health system and improve the health and well-being of all Coloradans. And so without further ado, I think we can get started. Welcome, everyone. Thank you for being here. All right, so the first question I think should be for Deborah and then Sandra. And this is a loaded question, so if you need me to repeat it, just let me know. Can you please, first, Deborah, share how mental illness has affected your child over the years, where you've seen the biggest gaps in care for him, and how this has affected your family and him?
Thank you so much, Tatiana. Hello, everybody. Well, for me, my own lack of awareness and understanding of mental disability is where I start. In my family, in my early environment, stigma was very much a part of our environment. We never talked about mental illness. There were a couple of relatives who had it. But that being said, it was thought of as something of shame, of disgrace, of dishonor. And therefore, anytime I would really think about mental illness, I would think that this is a problem that people have and they are dangerous. So that's a really tough way to begin with mental disability. And secondly, I was in denial. I felt with my son, who has a diagnosis of paranoid schizophrenia, that all would be well with him. I guess I believed he would snap out of it. Again, I knew nothing about mental disability, how it was treated. And so this major part of me, I am a holistic health therapist. I'm somebody who looks at healthy ways to exercise, healthy ways to eat, healthy ways for spirituality. I felt he grew up as an amazing person in this environment with me, and that he'd be okay. So that was really huge for me, looking at this within myself, because then where do you turn? So gap number one was my own way of thinking. So the next gap for me was the criminal justice system. And this is not a diatribe about negativities within the police system or the criminal justice system, but this is what happened to the two of us. And so there were two major police incidents. In the first incident, this was before I knew anything about my son's disability. He was disoriented. He was approached by two policemen. Unfortunately, they didn't understand what they were seeing. He didn't have the right response to their questions. They slammed his head to the pavement. He was taken to jail. That was the first incident. Then a year and a half later, he would have a similar incident. Unfortunately, this time, after the wrong injection or an overdose of an injection of a strong antipsychotic medicine that was given to him, he was left unsupervised. He walked to the park. He was walking around. He was approached by the police. Again, the wrong response. No drugs or alcohol in either case. The police were aggressive. He was wrestled to the ground, eventually taken to jail. So what I saw in this was a case of basically no drugs or alcohol, excessive force, and no following of training on how these policemen could handle a mental crisis. So that was number one. So then where do you turn? So the next gap for me was the healthcare delivery system. So when my son first came home from the first incident with a big bump on his head, I said, let's go to Denver Health. Let's go to the hospital. Let's get this checked out for a concussion and see what's going on. I did that. They said, everything's fine, ma'am. His vitals check out. I believe there's something wrong with you. I would get another obstacle. I would say, get a neurological exam for him. I'd take him there. They would say, everything's perfect with your son's brain. Again, there might be something wrong with you, ma'am. And then I would call crisis hotlines. What do I do in this kind of a case with mental disability? I'm sorry, ma'am, he's 21. There's really nothing we can do. I would have the police come over to the house. I said, maybe they would see he's gravely disabled. I was needing help with this. The police would say, there's no weapons, there's no knife, anything here. Sorry, there's nothing we can do. They got up and left. My third encounter, I would say, with issues with the disability system, with the health system, was just a major lack of being able to assist me in the present moment at that time to understand the disability and what I could do to help my son. So I'll leave it at that.
Is there anything else, and you don't have to, is there anything else you would want to say about how this all has affected you, your son, and your family?
Well, it's really affected. I'm a single parent. Most of my family is out of state. So that's one more degree of isolation. I think the greatest effect I feel or felt, I do not now because I've learned how to take steps to help myself, to help my son. But when everything was happening, I knew nothing, as I said, about mental disability. The stress for me was enormous. I mean, my stress was enormous. What else can I say about that? I mean, I can talk about physical symptoms, but the most important thing was anguish because I wanted to help my loved one. I just didn't know what was going on. I cared about him, and isolation, stress, not knowing where to turn, not really understanding because I had no diagnosis for a long time. The last thing I'll say was the HIPAA issue. At some point, my son would sign a document stating that I could have no release of information on what was going on with him. Well, this was huge for me because I would call to where he was located. They would basically say, we cannot help you with this. So, or we can't even answer any questions for you. So once again, the major issue for me was stress, overwhelm, not knowing what steps to take, particularly in the beginning, to get help even for my own medical care.
Thank you for sharing that. Sandra, I have the same exact questions for you. And the reason why I wanted to start here was just to give people who are attending kind of like a backdrop of like what people are up against here in Colorado, if they haven't had their own personal experience with mental illness. And so, again, the question is, or the questions are, can you describe how mental illness has affected your child over the years, where you have seen the biggest gaps in care for your son, and how that has affected your family?
Thank you. Where there are some similarities with Deborah's story, there's definitely major differences also. My son had his first psychotic break 11 years ago. That was right after his freshman year of college. At that time, I went to crisis counseling because I was a mess. And the crisis counselor told me Colorado is dead last in providing services for adults with a mental illness. You should move to any other state because your son is going to need care and he will not get it in Colorado. It has taken 11 years, but I can say now my son is getting care. It has hijacked my son's life. My son had so much potential. And I would say that today, due to his journey, he has put so much potential in a different direction. He is my favorite person to be with. He is amazing. He is the kindest, most empathetic young man I have ever met. I am so amazingly proud of him. The gaps I find are the care needed before incarceration to help prevent incarceration and the care needed after incarceration. We had dozens of interactions with police officers. And I will say that the police officers had a much better grasp on severe mental illness than the healthcare providers, such as they would know Drew needed a 72-hour hold. Yet the facility said, no, he's not a harm to himself or others. Please understand at this time, I was being assaulted and I ended up in the emergency room several times, but he was not considered a threat to himself or others. He also had 2 back-to-back suicide attempts. So after the first one, he went to Aurora Health for a 3-day hold, was referred to a therapist. He had 3 visits with her. Then he almost completed a suicide attempt. I came home and he was unresponsive in the bathtub, and I'm very grateful to the first responders. He was then sent to Johnstown, where I almost called 911 to try to get him released because these 72-hour holds are holds. They are just that. They're not treatment. Whereas when Drew first went in, there was still some remnants of treatment. Some individuals would go into these facilities to get their meds adjusted, but that was no longer happening. So as things, as Drew went deeper into his illness, I begged. I went on TV. I wanted desperately for my son to receive treatment. But again, they didn't consider himself a danger to himself or others. Before he was, I think it was his 3rd arrest or his 2nd arrest, I had been calling for a welfare check, and they said we could only do that if Drew will open the door. And I said, well, then I guess I wouldn't need that welfare check, would I? I was calling his providers to get services, but due to the Housing First model being taken, I think, in an exaggerated manner, if you're in long-term housing, you get a therapist, not a case manager. And then if you're not in long-term housing, you get a case manager, not a therapist. And Drew needed both at the time. He needed a case manager to help him navigate not losing housing, to help him navigate not losing employment, or getting the treatment that he needed so he could take a break from employment. What ultimately happened is Drew was in a mental health assisted living facility. I got a call on a Monday and they said they were evicting him. And I said, okay. I said, why are you evicting him? And they described the behaviors. And I said, so you're basically evicting my son because he is demonstrating schizophrenic behaviors. And they said, well, yes, but his needs are greater than the care we can provide him. And I said, then doesn't it make sense to refer him to someplace that can provide that care? And they said it doesn't exist. At that moment, if Drew had been able to receive a higher level of care, what happened in the next 4 hours would not have happened. I asked if they would place a 3-day hold on Drew, but they said again, he's not a danger to himself or others. And I said, I beg to differ. Please look at his history. Drew was arrested 4 hours later and was looking at the potential of 26 years in DOC. While he was in DOC waiting for trial, not DOC, in Denver County, his symptoms worsened and he was declared not competent. While he was on the wait list for the state hospital, it is nothing less than a miracle what happened. Within the Denver County Jail, they began a pilot for their restorative mental health pod. Drew spent over a year in that mental health pod, and he is voluntarily on his meds. He went to groups. When he was being released, his psychiatrist called me and spoke to me for an hour. No psychiatrist previous to that had had the time of day, even when Drew signed releases, to speak to me. And that hour was so very invaluable. We were able to get him set up with case management care before he came out. And because he was medicated, he was able to come home. If he had not been able to come home, this would have ended very, very differently because there was no place to release Drew to. I had called several places and they said, well, call us when he gets out. And I said, well, then it will be too late because he will be on the streets. The places that were available really concentrated more on the sober living aspect and not on the mental health support systems. What I've often explained to people is what is in Denver Health, in the Denver County Jail that is actually staffed by Denver Health. We need that on the outside, that exact very same model on the outside for individuals to get treatment before they end up in our judicial system, and for individuals with a severe mental illness to receive the treatment and support that they need once they come out of incarceration. I'm very thankful. I think it is very showing that in the state of Colorado, the very best mental health care that is available for individuals with a severe mental illness is within our jails. And I will say, and I will stand to get that treatment available on the outside.
Thank you. I was actually going to ask you to talk about that because I remember when you first told me that in an interview, how shocked I was. And so just to keep up on time, these are huge issues, right? And there's so much to talk about. We won't be able to get to everything, but I wanted to see if Vincent first could talk about, and then Frank, this same question. Like, where are you seeing the biggest gaps in care for people with serious mental illness? How is it affecting them? And why is this like this? If you can try and tackle these.
Sure. So I just mentioned that May was Mental Health Awareness Month, and so we did a little historical retrospective about the state of mental health care in Colorado through the history of mental health Colorado back in 1953, and it seems to have cycles of great interest where there's a reckoning amongst state leadership that access to care needs to be enhanced and some steps partaken. And then it subsides in priority among other state priorities for a time and then resurges again. And the way I look at it, I think it has a lot to do with population growth and the extent to which our cultural background and our sense of shame around mental health conditions has kept us from really reckoning with our population's need for care. We were always surprised by the extent to which we need greater access to housing, healthcare supports, and services for people with serious mental illness. And it's inevitable when we look at populations. And there's an organization called the Treatment Advocacy Center that does sort of population analysis and demographic recommendations and suggests that, as a rule of thumb, it would be good to have 50 inpatient psychiatric beds available for every 100,000 people in a population. And on that score, Colorado falls dramatically short. Because on that score, we would need something like 3,000 available inpatient psychiatric beds statewide. And it's just because serious mental illness should not be a surprise. It comes with the territory of being a human being. And so just as we expand E470 and other road systems to accommodate growing populations, we should apply our planning intelligence to expanding our array of services to accommodate these needs. And, back in 1953, when Mental Health Colorado got started, the state had something like 5,720 inpatient psychiatric beds. And in 2023, we got about 482 of those beds. And yet the population has grown dramatically in that time. And we have not built adequate capacity for care.
Thank you for that good data. I'm going to come back to you about that soon. And I was wondering if Frank, if you want to add anything to that, if you need me to repeat the questions, I can, if that's helpful.
No, I think, everybody makes great points. I think the stories that Deborah and Sandra shared highlight the gaps in the system, quite well, unfortunately. And, it's heartbreaking to hear. I think Vincent sort of, highlighted the things that I was going to highlight in terms of the lack of access to inpatient beds. And one of the things that certainly agree that there's a trend along population growth. We just don't keep up well. Our system doesn't respond nimbly to the way that Colorado specifically has grown by leaps and bounds. The other thing that happens is there's a cycle within mental health where we swing from institutionalization to community-based care, law enforcement, and forensic involvement, and then back to this clamoring and obvious need for more beds. But within Colorado's sort of tight budgets and fiscal situation, whether that's due to Tabor or other factors, there's a fight over, and there shouldn't be, but there is a tension between community-based care and inpatient-based care. And to have a functioning system, you need both. And so one of the things that has happened over the last decade is that Colorado has found itself as a part of a lawsuit related to incompetence, the ability to provide treatment and address competency to stand trial. And those individuals have filled up our state institutions, our civil beds, those 480 some beds that Vincent just described. And so there is essentially no access to our civil beds, which the community mental health center system historically used to manage individuals with serious mental illness. And that's something that needs to be flipped. We need more inpatient beds on the civil side. That's before somebody gets involved in the criminal justice system, so that we can prevent individuals becoming involved, competency being raised, and taking up a bed in the institute, so that they can stand trial.
Yeah, thanks. Since you're already sort of on to the next question that I had, which I think is really important, which is, what are some ways that state leaders or nonprofits or even arguably individuals can try to address some of these issues? I don't know if there's we call them solutions in journalism, but is there something that could be done right now to try to address at least one of the things that Sandra and Deborah said, right? They alluded to problems with incarceration for people with mental illness, not being able to get the care they need from, housing organizations and also healthcare organizations alike, and many other things. And so I was wondering if anyone has an idea for something that could work to try to improve the system for people with mental illness, especially people with severe mental illness. Anyone can go first.
I mean, I'd jump in and just say you're seeing some solutions standing up in some communities, and I guess I would point to Larimer County and their Longview campus. So, that county in particular, through a tax initiative passed in 2018, has built essentially a one-stop shop that includes law enforcement drop-off, that includes respite care, longer-term stays. And so that's the type of example of a community coming together, putting everything under one roof and hopefully, addressing a crisis before criminal justice involvement and preventing the exact story that Sandra just shared. And I think I think the results from the Longview campus are showing that there's a pent-up demand for this type of care. There were expectations that were surpassed in the first 24 hours that those doors opened. 16-bed unit was filled within 24 hours, and that data, and those results continue. And so, fortunately, I think you're starting to see some of these types of facilities being stood up in different communities. Denver, which also passed the tax initiative, is developing a crisis campus as well, and other communities are partnering to build these one-stop shops, for lack of a better term. Really, you can get crisis intervention, get your substance use disorder needs met. In addition, get you connected to resources, and really it's meant to be a support, as I mentioned, to law enforcement that needs an intervention before an arrest is made.
Does anyone else want to add to that? Question is, what could be done to try to improve the system? Or if you can't answer that, what do you need in order to care better for your loved one who has mental illness even?
I should add that, repeating myself a little bit, if we could increase the acknowledgement that there is going to be a need for a varying levels of care for a significant portion of any given population, and not be surprised, as we seem to be surprised all the time in community after community, when it turns out that people living with a serious mental illness or experiencing a mental health crisis are there. It's almost like we're always surprised about that. And, inpatient psychiatric bed is one level of care, but preferring least restricted settings for people, just having some kind of care management in place for individuals who may need, shorter term inpatient, but long-term care management and navigation of other available support systems. That's just going to be part of any human population at any given time. And we should be building that capacity, anticipating that need.
I would like to add in here that I think a couple things, if we acknowledge them, will help break down stigma and will help, which will help create these services. And one is severe mental illness is treatable. I was told so many times, no, Drew's treatment resistant, that, anagonosia this, and, don't have your hopes up. He will always have this. And now I say, well, he was treatment resistant because there was no treatment for him. But now through the pilot program and through the services that he's getting through case management and psychiatric care, he's proven that SMI does respond to treatment. My son is so valuable to this community right now. He is performing at his best level right now at 31 after everything he has gone through. So treatment does matter. And then money is not the reason that we do not have these services. When I first started advocating for this, people said, oh, money, money, money. And I'm like, that doesn't make sense, because Colorado's taxes aren't low. They're not the highest, but they're by far not the lowest. I think they're pretty much in the middle range. And then they would say, well, Tabor. And I would say, well, but the money's there. So where is it going? And so while Colorado was 50th in providing mental health care, we were ranked 27th in how much money we're spending on mental health care. And I think that's really important to pay attention to, because the money is there. It is just not being spent in areas that result in increased and improved services. And one other thing, an effort that I'm making is to unmask mental illness, to make mental illness more acceptable. When I would go up and down Colfax Street, there were so many lovely people that were caring. But if we can make, just break that stigma down, so we can decrease that fear of the unknown that is there, I think that those three things would make a huge difference.
I just wanted to ask Sandra, my son, I'm going to say he's 7 years in with his paranoid schizophrenia, and he's living independently. So one of the things you were saying is, well, there is treatment for SMI. I'm really seeing it in my son. And again, my son is remarkable, but I just saw him a couple of weeks ago, and I can see some ebbs and flows in his mental status. I have to reach out now to his doctor to make an adjustment. And I know she's working with it, but you were saying you've had some success with treatment for, I believe, the schizophrenia. There might be another diagnosis for Drew, but for what you've gone through with him. And I just wonder, other than some kind of psychotic medication, what other treatment have you observed that's really assisted him?
So great question. So Drew has gone on to some parent groups to me, and the parents are saying, what can Drew tell us, right? And so when he was incarcerated, he did the DBT classes and some other emotional regulation classes that they
I don't
have.
know what DBT is. What is that?
Dialectical behavior therapy. And the groups that they have in the restorative health pod in Denver County were remarkable. And it's because the individuals leading the groups, they're with these individuals for their 40-hour work week. They're all right there together. They don't just see them for an hour a week. But also Drew really, the 7 spiritual laws, and even before his first psychotic break, he, would delve into different philosophies. But I can really see his growth through practices such as the 7 spiritual laws and the DBT in his emotional regulation. I do not know another single person on this planet who has his emotional regulation that he has right now. And I understand there'll be ebbs and flows in that, but the treatment does work. But it's not medicine alone, and it's not classes alone. And right now, Drew's switching medicines because he gained 60 pounds on the first medicine. His cholesterol is up, so there's a lot of room for improvement in our medications that are available.
I actually wanted to jump in. I think we have enough time to ask this question. I have a question for Sandra, and it is about their treatment also. Something I didn't think we would talk about, but I'm glad we are. And I was wondering if you want to say anything else in just a few minutes about the pilot program that Drew was in and why you said you think it helped him, especially asking this because I don't think a lot of people would think that people with mental illness would get help in jail. And so I was wondering if you wanted to say anything else about that.
Right. And I think this would be great for to really highlight that program. So it is in response to the lawsuit that had been brought up for the long wait to get into a state hospital. And so Drew was one of 12 individuals that were chosen for the pilot program. And I saw within weeks a change within him. And it was due to a few individuals in there that really take to heart the work that they do and are also very educated and very skilled in providing therapy. They're skilled in treating agonosia. They're skilled in motivating someone to take their meds. And so you have that support around you consistently for a long enough period of time. So Drew was in jail a total of almost 2 years, and he was in this program for over a year. And that length of time is really, really important. I remember before when I was working with people with addiction issues, and someone came up and they said, I just got out of a year of rehab. And I go, well, I know you're not from Colorado then. And she was from California. And I knew she was not from Colorado because we don't offer, at least at that time, and I don't think we do now, year-long inpatient programs. So, and those programs are available at 30 to 40 grand a month. And so there's no way that I can pay that 30 or 40 grand a month for a year for my son to get treatment. Yet when I talk to friends, such as a friend in Arkansas, their private inpatient clinics are required to have a certain percentage of individuals who are on Medicaid or just cannot pay. And she works in one of these facilities, and she said, I have no idea who's paying and who's not paying. And I think that really using that type of thinking is what we need to solve the situation that we're in right now. Also, where I appreciate this panel so very much, I feel I am more valuable now because I speak to my son and I get insight from him. It is the individuals with the actual lived experience who need to be out and have people like Frank and Vincent asking them questions and listening to what they have to say because they've experienced it. We've experienced it as a caregiver, but my son was tormented by this illness. He's the one who's of value to speak with.
Yeah, and I just wanted to quickly say, you mentioned the term anosognosia, I think a couple times, which was something I didn't know. And I looked it up. It's a neurological condition in which the person who has a mental illness is unaware that they have mental illness. And this is like quite common, I believe, for people with mental health issues. And
Right.
so, yeah.
For severe mental illness, it's at least 60%, I believe.
Yeah, thank you. Yeah, so I think this is a good segue into Chief Judge Susan Blanco's portion, right? Like, I sat in your courtroom twice this spring, and I learned a lot about the competency docket that you run in your court and about the people who come through your courtroom. And these are usually people who don't understand their court proceedings because of a mental health condition or traumatic brain injury or learning disability, etc. And they're accused of a crime when they come to you, and their court case pauses when someone raises concerns about them being able to or not being able to understand their hearings. And then at that point, your staff link them to whatever services that you can so that they can hopefully get restored or well enough to understand what's happening in their court cases. And so if that all sounds good, which I hope it does, I would love if you could tell everyone a little more about the competency docket, like what it is, why it matters, like how you've seen it help people with mental illness or not. Yeah, let's maybe start there and I'll ask more after.
Sure. So we definitely recognize that there were people, much like Deborah and Sandra's children, that were coming into the criminal justice system that for one reason or another could not understand the proceedings. Competency was raised and people were waiting roughly about a year incarcerated to go to the state hospital to receive services. And there was a lot of just concern around all of the courts, recognizing that we're resetting court dates. People were just stuck in the system that were pretty vulnerable populations that were really not equipped to be able to support, and what are we going to do in the middle of this crisis, particularly when COVID hit and nobody was being moved to the state hospital. And so competency court, when competency is raised, someone comes into our docket on a Thursday morning, and now we have a lot of community partners that are in the courtroom. So we're addressing transportation, medication management, mental health, substance abuse, medical needs, communication, technology, and lots of the things, housing, that create barriers for people to be successful when they are in the criminal justice system, particularly when we're talking about these vulnerable populations. And so when Deborah was talking about her son feeling, and she was feeling isolated and stressed out, coming to court, people feel like that even when they are not suffering with any sort of these diagnoses. But when families and people who are accused are coming into the court system and they don't have all of those basic needs and supports being met, the likelihood they're going to be successful is low. And if they're not able to be restored, meaning that they've sat in our jail for long enough, we turn them back out into the community and they're really no better for it. And so this system is really trying to address what is the underlying reason that somebody is struggling? How do we support those basic needs and create sustainable options for people to access so they don't have to be in a criminal justice system to receive those supports and those benefits? So now if you come to court, there are all sorts of different groups from within our community sitting in the courtroom, working with folks face to face. There are warm handoffs so people know who they're working with. Everyone is collaborating, communicating, and trying to be part of a solution. And then to Frank's point, we have this wonderful behavioral, health services new opportunity in this last year, which is our Longview campus, and having Summit Stone that runs that campus here in the courtroom, helping folks. We're trying to more and more increase the use of that Longview behavioral health treatment instead of incarceration, particularly for people who are low risk, have low level offenses. So we're intervening without the criminal justice system being part of that mix. So I think that's one part of it. And the last thing I would just say is, I've had a lot of people coming and sitting and watching court. And one comment that was very meaningful to me was when someone comes to court, it's really easy to feel like you're not seen, you're not heard, you're part of this large docket. But I think everyone in the courtroom really tries to meaningfully meet people where they're at, try to learn about what their needs are and listen and try to understand what kind of support folks need. It's a strange concept to think of criminal justice in a way that is trying to have a higher degree of kind of human element here and, trying to help support people where they're at. But I do feel that we have the right partners in the room and really are trying to make an effort. Having one judge, one DA, one public defender, all understanding how this system works really helps navigate folks that traditionally were getting stuck in the system.
Can I just ask one quick follow-up? I think
Sure.
I hope we have time. I think if I were sitting in the audience, I'd be wondering about kind of this like tension between, so we have Sandra saying jail has helped her son in some ways. And yet we have you saying like, this isn't necessarily where they need to be. And I think that's actually like how people widely view incarceration when it intersects with mental illness. And so I'm just wondering if anyone, this is not pointed at anyone, but can anyone try to help people understand like the tension between those or how they should like reconcile with that? Like, it seems like, but Vincent's eyebrows went up. So I don't know if that's me putting you on the spot, but I think it's something that's worth trying to unpack right now because it's something that at least I know I've been thinking about a lot and I am not really sure how to understand it.
I'm happy to speak to that a little bit. And, it's great that Sandra's son has experienced a unprecedented quality of care in the correctional setting. But that's a terrible, sad irony for a community that is supposed to be about human health and well-being. And, we talk a lot about preferring care, not cuffs, is what we're after. And all of that quality of care ought to be accessible to people in civil settings, not in criminal settings. And what we have done, because we've not built that civil capacity, is created a default pathway. And Sandra made some remarks about cost. Our Department of Corrections in the state of Colorado is one of the most costly of our state agencies. We spend over $1 billion on our Department of Corrections, and a significant, accounting for that is because we have stacked our Department of Corrections with individuals who have never been able to access appropriate levels of mental health care in civil settings, and our response systems are largely driven by law enforcement and criminal response systems rather than health-based response systems. And so we've created an easy funnel pathway for individuals with unmet health needs into a criminalized setting. And there we spend the money because we feel we have to at that point, because we have criminalized individuals, and folks in criminal settings are the only people in America who have a constitutional right to health care. So we just knit ourselves into a very ugly kind of situation. And while it's wonderful when jails do great work and when judges do great work with their competency dockets, it's the wrong system responding to what we all ought to know is a population mental health needs, and the earlier the needs assessments and interventions with appropriate levels of care, the better for everybody. And it's not that we need to be spending more as a public. It's we need to be spending better and more intelligently in a more pro-human way than we currently are.
And I agree 100% with Vincent. Thank you very, very much. I do want people to know just how serious it is that the jails are our mental health care treatment centers right now. When my first experience in the courtroom, he was there for a misdemeanor, and they upped it to a felony, and I was terrified. And so I walked down the street, barged into the DA's office. I was in tears. I was frantic. And they explained to me, well, he's going to get better. He has a better chance of getting mental health care with a felony. So now we can do something more. We can get, our muscles into this with that felony. And the other thing that I think individuals should know, that when I go to some of my parent groups, we strategize on how to get our children arrested, because we know that is the only way to get them off the street. We know that is the only way to get them on their meds. And yes, this is, it's a very poor reflection on society. It's a very poor reflection on Colorado. And I think now is the time for us to really move forward. I feel we have some synergy going with some new facilities and a new awareness of mental illness. And I would hate to see this opportunity fail. And I just wanted to add to, everyone's journey with mental illness is unique. So where this setting worked for Drew, it's not going to work for everyone. And so I think it was Vincent and Frank, but we need the step down settings, but then we also need alternative treatments. Dialectical behavior therapy may not work for everyone. Maybe some people need ECT, ACT. There's tons of different therapies out there. Where some people might respond better in inpatient, other people may respond better out of that. And then I'll shut up right after this. So regarding costs, when Drew was in the Solution Center, a nurse told me, we've already spent hundreds of thousands of dollars on Drew this year. She goes, if we had only put Drew in supported housing, like with the voucher, and provided wraparound services, we would be saving so very much money. Because at that point, that supported housing with the voucher and the wraparounds would have been the exact level of care that he needed, because he hadn't digressed all the way. And so spot on. We need to spend our money better.
Yeah. Thank you both. I want to ask one
that message.
Yeah.
Yeah.
I just want to ask
Tatiana.
one quick question of Susan. Oh, sorry. Were you going to say something, Frank?
No, I mean, it was really
was
just
gonna say
to
something
emphasize
when
that
you're ready.
message about spending the dollars in the right way. And the other point, I appreciate where you ended up there, saying, right, when hate for people to sort of have a takeaway of using that criminal justice system pathway as an intervention. And I know that, it, it, I know your son has experienced good care in a facility, but I would say that, like you recognize that that's not the case for everybody. And so, a Denver or a metro area jail may have more resources than a rural county jail. And I just say that and you're all nodding your head. It's obvious that, rural county, frontier county jails don't have the resources that the metro communities do. And individuals in those settings don't have access to the full continuum of healthcare. And you have some not just the possibility of picking up more criminal charges once you're in a jail. You also lack access to, occasionally people need involuntary medication intervention to disrupt very severe self-injurious behavior or assaultive behavior, and for the protection of individuals, they need to be in an inpatient setting versus a jail setting. I know that's the message that you're sharing.
Right. And so someone who was just a couple cells down from Drew committed suicide while he was in there. So I think that's case in point. If he had been outside in an inpatient setting, would that have happened?
I just wanted to add that I'm going through with my loved one the exact opposite. Because he suffers anosognosia, which means he has a lack of understanding and awareness that he actually has schizophrenia or a mental imbalance. So therefore, he's become so good at being able to tell the system or manipulate it to his end that he's just fine. There's nothing wrong. He doesn't hear voices, whatever you want to call it. He's been through the excellent, by the way, mental health court. And that is something, of course, that Judge Blanco is involved in. My son went through it in Denver. I cannot say enough about how they help with services once the person is on whatever period of probation they're on, to see how they can become a viable member of society. But with my son, in his case, he passed that with flying colors. But what I see now is he's not in jail. He's living independently. And yes, he is getting an injection. He's certified, so he gets an injection monthly. But I don't see him integrating, the word I'm looking for, into society. In other words, does he have to go back to jail to get those amazing services that Sandy mentioned? I mean, this is a young man of age 25. What is it? Maybe that's why I love this conversation, because this is also what's needed. Not everybody's in jail. Most people are out doing their best. They maybe can't live with their family, but they're doing their best to cope. And many of them not on drugs or alcohol, but they're just kind of floating. And sometimes I wonder, how long will my son be in this kind of suspended anosognosia type state where he could really do nothing? And I know that's not up to anybody, it's up to him. But that's my frustration for those of us who don't have loved ones in jail with that kind of amazing therapy that Drew was able to receive. They're pretty much, you take a medication and good luck, and that's it.
I could ask questions forever, but just to be fair, we've got 5 minutes before I would like to open us up to questions from whoever is listening. But I just wanted to ask Frank if you could share a little about a program or an initiative that your organization has done that you feel has improved care or life for people with mental illness. Like, how did it help? What was it about? And why do you think it was successful? And that sort of thing.
Sure, I appreciate the question. So my organization, the Colorado Behavioral Healthcare Council, is kind of a different animal. We're a trade association advocacy group that represents Colorado's community mental health center providers. So, I mentioned one of them, the Longview campus, is an example, and there are others, the Solution Center in Denver, Celaya has recently stood up a regional assessment center. Others are in the process of doing the same. I believe Boulder is probably the latest county doing that. So that's one of the trends I see. And one of the ways that CBHC helped support that was to change some of the regulations about how we license and regulate facilities to allow more mixing of services under one roof, if you will. So I think, there's a lot, Colorado's been through a lot of behavioral health reform. We have a long way to go yet when it comes to how we regulate and finance. But I think things are headed in the right direction. Be able to not just integrate behavioral health with physical health care, but really to integrate behavioral health within substance abuse, addiction and mental health care. So those are some of the trends, I think, and some of the ways that CBHC has been trying to get involved to offer people better access to, whole person care.
There's one question I have that I'm going to squeeze in for Susan, if you're okay answering. I'm wondering, I feel like I view your competency docket as kind of like a safety net courtroom, which is like, again, there's these like this tension between these two words that like you wouldn't think would be a thing. And so I was wondering, even there, on the docket, like who still falls through the cracks and why? And like, what do you need, or what does the court need to help them better, if that makes sense?
Yeah. So, well, I just want to say, I think we all are in agreement that if there's a way for people to access care outside of being involved in the criminal justice system, that is the number one preference. Unfortunately, sometimes people are in the criminal justice system, and once they're here, I think we have a responsibility to do something to help. But I would love for people to be able to access that help without having to come into the courthouse. And so, you asked the question of what could we be doing differently and what falls through the cracks. Right now, for us, because we have limited time to work with people, for example, if they're here on a class 2 misdemeanor, I mean, they're kind of in and out so quickly. We don't have fast enough access to services. We don't have enough housing, for example, up in Northern Colorado. We don't have enough folks that are really willing to take a chance and work with individuals. There's a lot of stigma still around having severe, persistent mental health issues. And so my biggest concern is when someone's entering into this system and we don't have the resources and time, we are too slow, and we just are not able to help as many people as I wish that we could. We're connecting people to a lot of, if they have a brain injury, we have a nonprofit that comes in here. There's an intellectual disability. We have the group that is tasked with that in our community to help. We have the ARC here, Foothills Gateway, and we have all these different groups that want to help, but we're still a bulky system and people need access to care quickly. And if there's a way to support them faster and give them access to those places that they could be getting without being involved in criminal justice, that would be the ultimate, I think, benefit. But yeah, I think I'm not advocating that there be a higher degree of incarceration for people, but people come in and Tatiana pretty quickly, they reach the halfway mark and we release them back out. And so part of our goal is how do we connect people with services before they time out of the jail system so that we can help support them? That's probably the best answer I can give you to that question.
Fair. And if anyone did not read the story that we ran about the competency docket, it does answer that question if you're wanting to read more about it. But thank you all so much. I hope that the people who attended learned something new. I know I did. And I will be reaching out to some of you to see if we can do some follow-up stories related to some of the info from this. And so I have the first question here. If anyone wants to answer, just go ahead and start answering. Someone says, it seems that hoarding is an issue for a significant number of senior citizens. Does Denver offer a similar workshop, or are there other ways to support or overcome this challenge? This is a really interesting question. I don't know much about, and from the time that I was reporting in Connecticut, I remember there was a task force there specifically working on hoarding because it was becoming such an issue. that the town was trying to support those individuals. So I wonder if anyone knows how to answer that, or if anyone has any expertise in that.
I don't, like you said, it usually, goes up to the municipal level, and I don't know if that means Susan has any input there, but I would reach out potentially to Colorado's Behavioral Health Administration for resources around interventions for that condition specifically. Wellpower is community mental health center in Denver that may have some insight in supporting that, and get local NAMI chapter as well, and get involved in access to those resources. They sometimes have classes on different conditions. Might ask NAMI, the National Alliance for Mental Illness, if they have resources and can make connections.
This is also an important question that probably will be easier for you to answer. What would be a good model for accessible, affordable, quality mental health care? Do any other counties offer this? A good model for accessible, affordable, quality mental health care. Anyone?
I'm very interested in the work that Minnesota's doing. Minnesota overall is doing a lot of good work. Also, what I would like to do is really look at those top states, which Minnesota is one of them, and really explore what models they have. I do have a friend in Minnesota, and her son has schizophrenia, and I know they have a different housing model, and it really, I've been very, very envious of their housing model for individuals with severe mental illness. And as far as any other countries, to you, Vincent, does anyone, I really haven't had enough bandwidth to explore what other countries are doing.
Yeah, I think the main point of comparison with other countries are the nations that have more of a sort of nationalized or universal healthcare system, where they sort of respond in alarm that we rely so heavily upon a criminal system and incarceration to manage mental health in this country. Other countries do a better job of making care and housing accessible across the lifespan for individuals who need it. That's just never really been a priority here in the U.S.
I'll say too, other countries potentially have different cultures and values around mental health. Netherlands, for example, has communities that integrate an individual with serious mental illness into a family-like setting. And I think, Vincent, you touched on this earlier in the conversation, but there's just an element of tolerance that's needed, acceptance, to allow people to sort of live, and define their own path towards recovery. And, if somebody is loud or, stinky in the community, that sometimes we just need to sort of let them be and maybe offer some help. But there isn't always necessarily, it needs to be a law enforcement intervention or some type of, forced intervention that if we can just get to a little bit more tolerance and wellness oriented, I think that would be a long way to go in our state and the country.
This is an interesting question too. How do you feel Colorado can better support the mental health needs of children and their families?
It's a whole separate panel. Colorado is currently under a settlement agreement for not being making access to treatment a priority for youth right now. So there's a host of different things Vincent and his crew are working on. Some of these, there was a bill passed that would set up a system of care, which is, an evidence-based model that other states have introduced. Colorado will be implementing one for youth and families with high acuity needs. And that, unfortunately, we don't have resources or haven't put up the resources yet for a system of care for all youth and families, regardless of condition. So we took a first step this last legislative session. There's a lot more work to do.
I'd just comment on that too. Before, it's been almost 8 years I've been on the bench. I was a guardian ad litem and a criminal defense attorney. And, some of the things I'm even hearing in this conversation, this panel, where people think that their families need to be criminal justice involved to get help, is a mantra that I heard for over a decade. And being a guardian ad litem for children, families felt like the beginning of getting support and help was to hope that their children would get assessed some sort of a summons, some sort of a criminal case to come into a juvenile delinquency system. I think we need to be proactive in offering people options and supporting and listening to families and what their needs are, and not having a system where things have to escalate so far before there's intervention at appropriate level of care for what kids need. We just have struggled with that for a long time, and we don't seem to be able to hit the mark. I think sometimes our system is set where you have to fail at lower levels of care before you can access greater levels of care. And we need to be more focused on giving people what they need rather than making them go through hoops before they qualify for what they actually need.
Yeah. This is an interesting, all these are really good questions. People often avoid seeking treatment for mental illness in the first place because of shame and stigma. Could a change of policy be enough to overcome that? Sandra, you want to say something?
No. Sometimes when I speak, one message that I really want to get out there is you don't need a policy to say, let's all be ethical people. And policy rarely does that, because policy can't change emotion. Just like abolition, when alcohol was deemed illegal, did people still drink? Yeah, absolutely. Policy cannot change a human's inner soul. I think what needs to be done to really bite down, on that stigma is a lot of unmasking.
Yeah, just to add to that, I totally agree that I don't think it's a policy change that can overcome that, because we need to really, you put it nicely, Sandra, in terms of unmasking. It's a shift in understanding and that recognition that mental illness is prevalent and is something that families have in common. I think that it would be rare, if not impossible, to find a family that hasn't had some incidents of mental illness in that family, and yet because of the shame, we don't address it. And I think that the shift in culture, I thought that one way to bring it about might be by creating sort of greater access or greater usage of the Psychiatric Advance Directive, which is like a medical power of attorney sort of thing for mental illness. It ought to be a rite of passage. If we could make it a rite of passage the way people get their driver's licenses when they're 16 or register to vote when they're 18. When you register to vote, you ought to have family conversations and understand that now that you're 18, because you're out of reach of family support for whatever your health condition may be. And so why not celebrate your 18th birthday by forming not only a medical power of attorney, but a psychiatric advance directive, and have every family have a conversation about the risk of psychiatric crisis and what might occur in that case. Not wait till the crisis is occurring when they're 22 years old. They have that conversation. Every family ought to have that conversation and take some steps to protect the family's ability to advocate appropriately to their loved ones.
And I just wanted to
I've
quickly
heard
add that one
maybe
of the
this
most
comes from a
amazing...
provider perspective. I personally have that in my background in addition to policy work, but there are ways that we treat behavioral health conditions differently than other health conditions. We ask way more questions in an assessment to determine eligibility for services than you do with somebody who has angina and walks in to the ER. We treat somebody, with a mental health condition much differently. We require much more paperwork of behavioral health providers than we do healthcare providers. Treatment plans need to be signed, by the client and by the treatment team on the behavioral health side, whereas the treatment plan, your doctor's office consists of their note. So, I completely agree that, there's, a cultural shift that needs to happen, but I do think policy and payment honestly drives behavior. and there are ways that we can treat behavioral health more like healthcare to reduce stigma.
Deborah?
And I just wanted to add the importance of conversations like this. It really isn't all policy. It's what everyone is saying, all of us coming together and expressing. And I just want to also say that in the BIPOC community, that stands for Black, Indigenous, Color,
People of
POC,
color.
people of color, anybody who's non-white, basically that becomes an even more exacerbated stigma in terms of finding services, in terms of finding health. But one of the solutions that NAMI has presented that I'm learning recently is they have a website. I'm going to have to look here at what it's called. It's called NAMI Sharing Hope, meaning that faith leaders and others in all diversities of religion, not necessarily just Christianity, but this is an initiative that is doing its best to bring conversations, people together, knowing that we can reach out to each other, be it in churches, be it in organizations. I think that is a wonderful website to take a look at. And that's a start. And NAMI.org, again, NAMIcolorado.org, I believe it is, has so many different initiatives working with support groups, conversations. And I think we've all mentioned this or touched on it, but being more proactive when our children are young in schools, having conversations with teachers, with parents to understand the kinds of issues that we might be seeing in our family that we're denying or not knowing what to do with it, but perhaps with conversation, school, church, spiritual experiences, people can talk more and listen more to one another.
Deborah, that is absolutely fabulous that you brought that up. I'm part of NAMI's interfaith committees, and I'm very, very excited about the work that hopefully will be done. I have several texts here. I mean, you could imagine how high my stack of, yes, I need to read this. But what I would love to have a conversation with is in certain times, the churches provided mental health care. Churches provided the hospitals. And there was a time when they were providing some really awesome care, really, really good care. And I would really like to explore that model of how to get churches back involved, or maybe expand the whole idea of what is a church to provide care. And I think what NAMI's doing is a really huge first step.
All right. So we've got less than 2 minutes, and where I wanted to end, and thank you all so much, was I think sometimes it feels like there's nothing that anyone can do to like help resolve any of these issues, or that they're powerless. And I'd like to think that's untrue. And so I was wondering if anyone wants to, in like 30 seconds, just say if there's anything that community members can do to help resolve any of these issues or not do, in your opinion. Maybe one person can go ahead.
I'll just take this opportunity to say something about how meaningful community activism is in a state outside of Colorado. When your elected officials hear from 20 people on an issue, that is a loud volume of activism. And so don't think that your voice doesn't matter in the state, but you do consider signing up for Colorado's grassroots network of advocates, the Brainwave. We mobilize folks with email writing campaigns and testimony at the Capitol every year on a whole wide variety of mental health related issues across the lifespan.
Great. Well, I wish we had a little more time, but thank you everyone for attending. If you want to reach me, I'm at Tatiana at coloradosun.com. Or if you want to reach the newsroom, it's newsroom@coloradosun.com. You can send more questions or comments or story ideas to us. And yeah, thank you all so much for being here, and I hope you have a great rest of the night.
Thank you.